Welcome to my presentation on folic acid deficiency anemia. This is case study 87. My name is Rebecca Edwards. I am a student at Liberty University School of Nursing in the FNP to DNP program, and this presentation is for the class Advanced Physiology, Pathophysiology, Nurs711. Patient case introduction. The patient WL is an 80-year-old man who is seen at the Veterans Hospital for a routine checkup. His primary complaint is, quote, "I've been feeling really lousy lately. I have no energy whatsoever and I'm always cranky." Upon questioning, the patient admits that he has been feeling weak and terrible for nearly 6 months. The patient denies any weight loss. Social history. The patient is retired after 42 years as a coal miner. He has heavy alcohol use, mostly beer, for 15 years. Previous medical history. The patient is a type 2 diabetic. He has had a seizure disorder for 17 years, but has been on medications for 3 years and has had no seizures during this time. Patient also has hypertension. Current medications. Patient takes phenytoin 100 milligrams PO TID, glipizide 20 milligrams PO BID, and trimeterene 25 milligrams PO QD. About folic acid deficiency anemia. Megaloblastic anemia results from a deficiency of folic acid. Folate is a water-soluble vitamin naturally present in foods. Folic acid is the synthesized form of folate. I wanted to include this in my presentation to clarify why you will often hear this disease referred to as folic acid deficiency anemia and folate deficiency anemia. Examples of food high in folic acid are fruits, green leafy vegetables, and liver. In the United States, folate has been added to grains. The body's daily requirement of folate is 50 to 200 milligrams a day. Dietary intake is necessary to meet the daily requirement. A deficiency can also result from inhibited absorption of folate in the intestines, an elevated pH, and interactions with certain drugs. An estimated 10% of North Americans are folate deficient. In the United States, this incidence has been decreasing as foods are supplemented with folate and the use of folate supplements are encouraged. The incidence of folic acid deficiency anemia is increased among alcoholics and among people who are malnourished. Increased amounts of folate are necessary for women who are lactating or pregnant. Women of childbearing age and non-Black Hispanic women are at the highest risk of folic acid deficiency. Low socioeconomic status and the institutionalized elderly population are also at an increased risk. Folic acid deficiency anemia pathophysiology at the cellular level. Folate is consumed and absorbed by the body and stored in the liver. Folate assists with the synthesis of thymine and purines. When there is an insufficient production of thymine, bone marrow cells undergoing erythropoiesis are affected. The result of the affected erythropoiesis is megaloblastic precursor cells. Megaloblastic precursor cells create large stem cells, also called megaloblasts, in the bone marrow that mature into erythrocytes that are macrocytic. This leads to macrocytic anemia. Back to our case study. What are the clinical manifestations of folic acid deficiency anemia? Pertinent subjective data. The patient states, "I have no energy." The patient states, "I feel weak and terrible." Upon questioning, the patient denies shortness of breath, headache, chest pain, sore mouth or tongue, lightheadedness, pain with swallowing, abdominal pain, and diarrhea. Pertinent objective data. The vital signs are as follows: pulse 110, respiratory rate 18, temperature 97.8 Fahrenheit, blood pressure 130/85, and oxygen saturation 95.5%. The skin is cool with normal turgor, pallor is prominent, and negative for jaundice. Head, ears, eyes, nose, and throat. Normal cephalic, atraumatic, slightly pale conjunctiva, negative for glossitis, and significant pallor of oral mucosa. The lungs, decreased breath sounds bilaterally with diffuse inspiratory and expiratory wheezes bilaterally. Cardiac, tachycardia with normal sinus rhythm. Extremities, negative for paresthesia, clubbing, and cyanosis. And neuro, coordination and vibratory sensation intact, and negative for ataxia. I've included pertinent lab results below. You will see in parentheses the normal range for these lab results. Glucose fasting, 185 milligrams per deciliter. Hemoglobin, 8.8 grams per deciliter. Hematocrit, 19.7%. MCV, 103. MCHC, 33.5. Red blood cells, 3.0. Platelets, 139. White blood cells, 4.4. Iron, 67 micrograms per deciliter. Folate, 1.7. Vitamin B12, 230. TIBC, 312. The blood was examined on a peripheral blood smear and showed anemia, poikilocytosis, large neutrophils with 6 to 7 segments, and macrocytic normochromic red blood cells. Please consider the following 3 case questions. 1. Identify 2 risk factors that have placed this patient at risk for folic acid deficiency anemia. 2. Identify the clinical manifestations, including laboratory blood test results, that are consistent with and relevant to a diagnosis of folic acid deficiency anemia. And 3. What is the significance of the absence of paresthesia and ataxia and the presence of intact vibratory sensation in this patient? Thank you for taking the time to listen to my presentation. On this page, you will see the references used.